number one, what is GIST, or gastrointestinal stromal tumor? How do we treat it? I'm going to spend a lot of time talking about imatinib or Gleevec, which is the drug of choice that we start treatment with for GIST. I'm going to spend some time talking about how we manage side effects, which is always questions that come up later on in the day. And then I'm going to mention about some of the options for imatinib-resistant GIST. Dr. Trent's going to go into this in a more detail, but I'll at least lay out the basics. So we'll start at the beginning. What is GIST? So this is actually a picture of any of your gastrointestinal organs. So your stomach, your intestine, even as far up as the esophagus, your food tube, and the rectum. And so what we see here is a picture of a cross section. So this is the center lumen, or the open area where food and digestive juices all pass through. And then this is the outer layer. And in between you can see that there are these layers of muscle that act to churn your food and move things forward. And so gastrointestinal stromal tumor is the most common type of sarcoma or soft tissue. Can't hear? Louder? I'll try to yell. Okay. So gastrointestinal stromal tumor is actually a cancer of a very special cell called the interstitial cell of Cajal. So the interstitial cell of Cajal is the pacemaker cell. It's actually a nerve cell that communicates the signals from your brain into the gastrointestinal organs to tell them to churn, okay? So they're kind of nestled here in this muscle layer. And because all of these cells occur everywhere along your GI tract, that's how come you can get a cancer of them, or GIST, at any point along the way. And so what happens is that the interstitial cells of Cajal get a mistake in the programming that tells them how to grow and how to divide. And when they're growing uncontrollably, that's how you get formation of a GIST. So here's my little picture of an interstitial cell of Cajal. And what you see is that there's a protein on the surface of these cells, normally called KIT. And the normal function of KIT is that there are various growth signals that are in your body that regulate whether these cells divide or replace themselves. The KIT acts as a receptor, an antenna, that then carries those signals into the workings of the cell and leads to further growth and metabolism signals inside. And so what happens is that 80% of GISTs have a mistake in the KIT protein. Let me actually go up one second. They have a mistake in the KIT protein that leads to KIT always being turned on. So instead of this normal pathway where the KIT relies on the growth signals coming from outside, it's always turned on, and so you get this perpetuation of more growth signals that are abnormal and shouldn't be happening inside the cell. And so this is another picture of that KIT protein. This is the part that's outside the cell. This is the part that's inside the cell. And you can have mistakes anywhere along the gene, which is the DNA that codes for how that gene is working, how the KIT protein is manufactured. And it's important that we know where in the protein the mistake is happening. Some of them can be out on the surface, and we talk about where in a gene something's happening, like a mile marker or like a road map. And so those terms are called exons. You'll hear that later on. So if you have your mistake in the outside part, it can be occurring in exon 9. The most common place for these mistakes to happen is actually inside the cell at exon 11, or mile marker 11. These are less common but important, and I'll talk about them a little bit later. So one of the things we push for, and you should be pushing for too, is that if you're looking at potentially using imatinib or Gleevec for your treatment, or even if you have what is termed a high-risk GIST, which I'll show you in a minute, we're actually sequencing almost everybody now. Sequencing refers to mapping the tumor itself and figuring out where exactly that mistake is happening. And this is important because up to 20% of GIST may have a mistake not even in KIT. There are other genes that can be broken and lead to the growth. And this is really important for treatment. So I'll back up a second. Who gets GIST? So there's really only about 5,000 new GIST patients per year. They're very rare, as you can imagine. This is not breast cancer that we're talking about. Most common in 40 to 60-year-old patients. Men and women are about equal. There's a few patients that are kids, very, very young, completely different disease, and I'll talk about that a little bit. Most commonly, patients might have fullness in the abdomen or some pain, pretty vague symptoms, nausea, vomiting, feeling full early when you're eating. Sometimes these will bleed, and so people can present with a bleed through the GI tract as their first sign. And then there are some patients that might have a scope done, an endoscopy, where the gastroenterologist goes from above with a little camera. And this is a picture here. This is the camera actually inside that lumen, the hollow area inside the stomach. And so what you can sometimes see is a tumor that's coming right out of the wall. And sometimes you don't see these on a CAT scan first. You might have to do a scope in order to see them because they're growing from inside of that muscle layer. It's not very obvious sometimes. There are no known risk factors for GIST other than the rare types of GIST that could be passed down in families, which are more often that pediatric kind, the one that's happening in kids. But in general, these are not hereditary. So how do we treat GIST? So let's say you've had a scope, they found this tumor. We have two worries. Number one, we have to control the tumor itself, which is called local treatment. We have to make sure that that tumor is removed surgically, if at all possible. The other problem is that sometimes these higher risk GISTs, which again I'll mention in a little bit, there's a problem. These tumors can leak cells into the fluid in the abdomen, or they can leak and seed into the liver, which is the most common place for these to go. So if that happens, then you get metastasis or spread of the cancer, and they can sort of set down roots in this new location. Again, most commonly somewhere else in the abdomen or in the liver. So what we want to prevent is that metastasis. If there are any cells that leaked out during the surgery or in the process of the tumor growing, we'll talk about systemic treatment, which is medicine that goes everywhere to try to prevent those cells that might be floating around from implanting somewhere. If that's going to happen, it usually happens within 2 years of surgery. And additionally, if you're one of those 20% of GIST patients that don't have KIT as your problem, that's not what's broken and driving the tumor, you could really be wasting a lot of time trying to treat with imatinib if it doesn't bind to the right site. And this is what I'm referring to. So, like I said, 80% of GIST have a broken KIT. KIT here, 70% exon 11, 10% exon 9. But then there's all of these other different genes that can be broken in a small fraction of GIST patients, and we're learning more and more every day. One that we really want to catch is exon 18 PDGFR. So this is platelet-derived growth factor, and there's a particular mutation that we see a fair amount called D842V that is completely resistant to Gleevec. So if you don't do mutation testing and know that ahead of time what's actually driving the GIST protein, you could try to use Gleevec and it would not be effective at all. More and more we're finding these mutations in these other genes, and it may suggest other drugs that we could try on a clinical trial or sometimes off-label, and I'll show you a chart of that later on. If you really don't have any identified mutation, anything that we can find, some people we call wild type, which is really not being used very much anymore because there are very, very few patients that do have wild type. But it's important to know that as well. There's actually a special clinic at the NIH in Maryland that meets once or twice a year, and it's just for wild type patients. There is a completely different biology behind those tumors. So let's assume, though, for the sake of our talk right now, that you do have a KIT mutation, okay, the most common kind, and you're going on Gleevec. So back in early 2000s, these are the first patients that were treated with Gleevec to try to control GIST tumors. So these are pathology pictures, and what you can see here, each of these little blue cells in this picture is an actively growing GIST cell, okay? So this is a tumor cell. They do special stains using this brown marker to look at the rate of growth, which is this Ki67, and then also CD117 is the other name for KIT. So you can see in a GIST tumor, it is covered with KIT protein. After 1 month of Gleevec, just look at the difference. There's almost no living cells here, and the ones that are, the KIT expression is way, way down, okay? So this was sort of the early proof that you could actually block KIT using this drug. And then this is a picture of something called a CAT scan, which I'm sure you guys are familiar with. A CAT scan measures the tumor in a sideways fashion. So imagine this picture, somebody's laying on their back with their head into the wall and their feet coming towards you and sliced like a loaf of bread from head to toe. So here's the tumor here. You can take my word for it. This is your liver. And this is this huge, huge GIST tumor nestled here between the stomach and the intestines and also in the liver. And again, this is all those actively growing cells. After Gleevec, you'll see here that although the tumor looks about the same size compared to before, it's dark gray. And instead of these lighter gray lumps and bumps inside the tumor, it's all this pocket of liquid. And so this is called necrosis or cell death. And this is what we're looking for, especially early on when you're treated with Gleevec. If you were to go to surgery and then you looked under the microscope, you'd see very much what we saw in those other pictures, that there are very few living cells left, and it's all replaced with this liquid dead cell material. Another trick we're using earlier on is something called a PET scan. A PET scan uses radio-labeled sugar to measure the growth of the tumor cells. And so when the tumor cells are actively growing, they're using lots of that sugar. And so that tracer, the sugar tracer, will get taken up by the cells and it will glow on a PET scan. And so here, this patient has tumor here, here, here. It's actually dark on this type of picture. But what we have found is that even just a few days or weeks after starting Gleevec, that signal shuts down. So even before the tumor shrinks, the cells are going into hibernation. That growth and that activity and taking up of the sugar is shut down pretty quickly. And so this is 4 weeks after starting Gleevec, and you can see that there's really no evidence of any active tumor. So this drug works really, really quickly. One other thing I'll just mention before we leave the CAT scans. So if you didn't know what you were looking at, for this patient, this is January, March, and then October, here's his tumor, and you can see that it's actually getting bigger as we go along. But look at the color difference. Again, this is late at the end of his treatment, but it's all dark gray and liquid appearing compared to this brighter, more dense tumor that we started with. And so this is something called pseudo progression. And if you don't realize that GIST behaves in this funny way, you might think this patient's progressing or growing on treatment. But actually, this is a really good thing, and this is what we like to see. It just sort of expands and becomes this liquid ball. And if you're ever unsure about whether a patient is progressing, we'll get a PET scan. And again, that really seals the deal that this tumor is no longer taking up sugar, it's not growing. This is a dead tumor and a good response. Okay, so using Gleevec after surgery. So for intermediate or high-risk patients, which is what I told you about, we will routinely recommend consideration of Gleevec to try to prevent the chance of this coming back, okay? So we know that 80 to 90% of high-risk patients have the chance of it coming back either in the abdomen or in the liver. And so how long do you really need to be on it? That's a question that's still under a lot of investigation. And so this is a clinical trial, one of the first ones that try to answer this question. And what I'm going to show you here, these are what we call survival curves. So each of these lines represents the percent of patients that are free from having their tumor come back, and then this is over time. And so you can see here that in this picture, 100% of patients start out free of their disease, and it slowly drifts down as a few patients will have their GIST come back. So these two lines reflect either Gleevec being used for 1 year after their surgery versus a placebo or a sugar pill. That's the bottom line. And so overall, this trial had about 700 patients that were put onto this protocol, and you can see that there was a difference in patients that got Gleevec versus patients that didn't, that just got a sugar pill. And then when they split this out and tried to look at who really was benefiting, this is a picture of the high-risk people. So the high-risk people, you can see there's a tremendous benefit here. So at 1 year, for example, about 30% of patients had had their tumor come back, whereas only about 3 or 4% of patients had had their tumor come back when they were on Gleevec. So this was the first study that really suggested that using Gleevec after surgery could prevent these tumors from occurring. So then the question was how long? That trial was for 1 year. This trial, SSG, tried to look at 3 years, okay? And so 200 patients got Gleevec for 1 year after surgery, 200 got Gleevec for 3 years after surgery. And when they looked at what we call the 5-year recurrence-free survival, what percent of patients were free of tumor at 5 years, if you only got it for 1 year, only 50% of people were still clear. If you got it for 3 years, 2/3 of people were still clear. So this suggested that 3 years was probably better than 1 year, again, for these high-risk patients. And actually, this wasn't just high-risk. This is actually intermediate and high-risk patients for this one. There's another study that's going on now looking at 5 years. All the patients have been put on that study. We're waiting for the data. It's going to take a little bit longer to see those numbers, how many patients have come back at some point along the way. But the early evidence suggests that longer is better. And so the recommendation now is at least 3 years for intermediate to high-risk GIST patients, if you're going to do it. That being said, for our highest risk patients, Dr. Trenton and I will routinely recommend that patients are staying on it even longer, although that's not been proven in any studies. But I'll show you some data later that sort of suggests why we are going that way. So I'm going to switch gears a little bit. This is the same type of thing that we can do for patients that need to have their tumor shrunk so that a surgery can be performed. So one option is to give Gleevec first and try to get one of those responses like I showed you, where the tumor becomes liquid and not living and growing. And we talk about these patients in Tumor Board, where all of us get into a room and look at scans and look at the pathology to try to make these decisions. So we consider Gleevec up front for patients that have borderline or frankly unresectable tumors, meaning they can't be removed completely by surgery. We also look for patients where they'd have to have their organs removed, so lose a kidney, spleen, a big chunk of liver, or maybe a part of your blood vessel. Usually we'll consider trying to shrink it first for those situations. And sometimes if somebody has the big tumor and maybe 1 or 2 sites where the tumor is spread, we'll consider that as well, because there's evidence that patients still do better even if the tumor's already out of the barn, so to speak, to try to remove everything. And then for metastatic disease, for patients that have already progressed, the goal again is to sort of delay the time to the GIST becoming resistant, okay? So if you've got a lot of disease and surgery's not looking like it's going to make a lot of sense, we're trying to prevent and delay the time for your GIST to be stable or steady. What we know is that, unfortunately, most GISTs, even though they're sensitive to Gleevec to begin with, will ultimately develop another mistake, another mutation, and figure out a way to outsmart the Gleevec. And so we have to try to keep this slowed down as long as we can, and that's why we tell people with metastatic disease to stay on the Gleevec continuously until it stops working, okay? And I'll show you some information about that. Sometimes if you develop a tumor that's growing on Gleevec, you can bump up the dose, and that will oftentimes be enough to reverse that and to get you some more time on the Gleevec, and I'll show you that as well. So this is a picture from the MetaGIST study that looked at 1,600 patients with metastatic GIST, so GIST that's already out of the barn. They were treated with either 400 milligrams of Gleevec, which is the standard dose, or a double dose at 800. And basically, it didn't really matter so much whether you got the low dose or the high dose to start, except if you had exon 9. So they went back and looked at the patients, and the people that had exon 9, which is the one that's out on the surface of the cell, they got better. They did better overall if they had the high dose of Gleevec. This wasn't true for everybody, though. And so another reason to know ahead of time where your mistake is, where your mutation is. You can see here, though, that even on the Gleevec, about 50% of patients will progress. Their tumors will grow on Gleevec by about 2 years. So what it's telling us is that although the Gleevec looks great and all of these cells are dying up front, there's still residual cells that are kind of hibernating, but they're not completely dead. So we still have a lot of work to do. So a lot of patients who have now been on Gleevec for 3, 4, 5 years, and they have disease that's spread, and they're stable. Their tumor hasn't developed resistance yet, which we've seen. They want to know if they can take a break on the imatinib. Maybe the side effects are getting exhausting, we're having some issues. And patients will ask if they can come off. I had one lady who came off to get pregnant, unfortunately. And so what happens is that if you come off the Gleevec, these patients most patients will grow again. So this study here, 400 patients, they were randomized, meaning a computer put them into one group or another for either 1, 3, or 5 years. Okay, and so the patients either were randomized to continue on Gleevec indefinitely, or they had some people come off. As long as they hadn't progressed, the people would stop their Gleevec. And then we were watching to see what happened. And the question was, if they started to grow again off the Gleevec, Could you restart the Gleevec and have it be the same effect? And the answer was that yes, most people could. 96% of those patients who grew off Gleevec could restart it and it would still work. But the idea is that when you take away that pressure from the Gleevec, any cells that then can grow may have more opportunity statistically to, by chance, develop a new mutation that might be resistant to the Gleevec. And this is really where the numbers don't lie. If they stayed on Gleevec for 3 years, 5 years, or 1 year, about 8 out of 26 patients had their disease come back, whereas if they had stopped, 26 out of 32 patients had their disease come back. And these numbers held true at 3 years and 5 years. At 5 years, if patients stayed on Gleevec for 5 years, no one had their disease come back. Granted, this is a very small number of patients we're talking about, whereas almost half of them did if they had come off the Gleevec. So this is telling us that the Gleevec's holding it steady, but it's not completely getting rid of the root of the problem. So to summarize what I've told you so far, the intermediate and high-risk GISTs have the ability to leak cells, okay? And so even if you take out the tumor, you're still at a high risk of little cells forming new tumors either in the liver or other places in the abdomen. Imatinib can result in dramatic shrinkages and stabilization up front, and oftentimes you can miss it if you're just looking at with regular CAT scans. We definitely want to use surgery when we can, when it's possible. Multidisciplinary evaluation with a surgeon who's familiar with GIST is really, really critical. Imatinib controls the growth of cells for many years. There are some patients in the LifeRaf group that have been on Gleevec for 10 or 15 years. I mean, there are some people out there where their tumor just doesn't develop resistance. We don't understand why that is, but we know that if you come off of the Gleevec, these cells will wake back up and start growing again. So we need new drugs that are effective against those resistant cells when the Gleevec stops working. And we also need to find drugs that will kill the GIST up front instead of just putting it into this hibernating state. And I think those are the big goals where we need to move in the next few years for GIST patients. So shifting gears a little bit, let's say that you're on Gleevec, you're doing great, and then you go into the clinic and your doctor says that you've progressed. So progression means the tumor is growing somewhere, but there's different types of progression. So the little stars represent a lesion that's growing, and the solid ones represent a lesion that's sitting there and not doing anything. This is a picture of a liver. So you could have widespread progression, meaning that all of the tumors seem to be growing at the same time, or you might just have one spot, one tumor that's growing where the rest of them are sitting there not doing anything. And so what we will often do in that scenario is we'll actually try to understand why it's developed resistance in that one spot, and then try to do something about just that one spot, maybe not all the rest of them that are sitting there stable on the Gleevec. So this is just a picture showing that we've studied what happens in these cells that become resistant to Gleevec, and what we often will find is that they develop new mutations in these more resistant areas of the KIT protein, okay? And so this is sort of the evidence as to why these tumors have broken through, and there are trials going on now that are looking at trying to find new drugs to target those specific resistant mutations, like exon 13 or exon 17, and Dr. Trent will tell you more about that later. So if you have just one of these tumors that's growing, a lot of times it's in the liver. That's a common scenario. And so we have our colleagues, our interventional radiologists, who have figured out amazing tricks to try to kill just that one lesion, not necessarily having to go through surgery, although we've done that also. So this is called ablation. And what happens is in the operating room or in a sterile environment, they'll put these probes, using a CAT scan to guide them, they'll put these little needle probes right into the lesion where the problem is. And then they do a variety of cool different things. They can put chemo in sometimes. They go do a different technique. They go through the blood vessels, or through these special needles, they can freeze it, burn it, or electrocute it. Okay? And they do this without obviously causing harm to the rest of the body. It's a very focal treatment right in the location where the problem is. You can also sometimes use a special kind of radiation called stereotactic, or cyberknife is the other name for that. And that can also do the same thing. So focused damage right at the area where the problem is. The electrocution idea, we're doing more and more of it, and it's called nanoknife. You guys might have heard of that. But this is actually a really effective procedure that doesn't have some of the side effects of the other treatments. If everything's growing at that juncture, we really talk about changing your treatment. And the options will include increasing the Gleevec to 800, like I mentioned. Sometimes that's enough to get over the hump. Looking at second or third line drugs, sunitinib or Sutent, and regorafenib or Stivarga are the two drugs that are approved when the tumors are no longer responding to Gleevec. Oftentimes we'll biopsy the area that's growing to try to understand what's driving the tumor, this new resistant tumor. Always clinical trials are worth looking into. Dr. Trent will talk about some of the new ones that we have in the pipeline, but this offers you the chance to get something that may be a little bit better than the standard treatment options, or not, but at least you're participating in the cutting edge of what's known in the research and in the science. And then there's a bunch of other tyrosine kinase inhibitors, which is the big family that Gleevec is a part of, that we will often use for patients that need something else. This is just, again, progression curves here for sunitinib. So in patients that progressed on Gleevec and then were assigned to either Sutent or a placebo, you can see a dramatic improvement in the patients that got the drug compared to the ones that got placebo. Actually, Sutent works quite well for people. And the same thing with Stivarga. So Stivarga here is in the yellow. So this is a busy slide, but what this shows you is that using that pie, if we understand where your GIST fits into the pie, we will try to guide you towards different drugs that may be more effective than the traditional KIT protein or KIT blockers like imatinib. So this is some of the other KIT inhibitors that we have used either in a trial, which is always preferable, or off-label, including dasatinib, nilotinib. Votrient is one that we're using more and more of, pazopanib, and axitinib also falls into this family, although there's not a lot of data yet to suggest how active that's going to be. If you have that special D842V mutation, the one that's completely resistant from the get-go, there are two drugs, maybe more, but two to my knowledge, that are being tested specifically for those patients. Important to know about these trials because we'll send people to those if it's at all possible. And then these are other drugs that have been designed for different types of tumors, but based on the particular gene that seems to be broken, we can guide you towards treatment that makes sense. So the take home from all of this is that we really want to understand your particular GIST and customize your treatment so that it fits with what we understand is driving the tumor, what's going on. These are just a short list of some of the trials that we have at Miami and elsewhere, just so that you're aware, and Dr. Trent will go through this more. There's a new drug called masitinib. Masitinib is basically like Gleevec. It's designed to hopefully be more effective than Gleevec, and so there's two trials that we have either up front or at the time of progression on Gleevec. So for that trial, it's actually masitinib or Sutent that you would get. And so you have the option to participate in a new drug that's being designed to take the place of Gleevec potentially. SARC-029 is coming down the pipeline. It's on hold temporarily, but this includes a MEK inhibitor, MEK, plus Votrient, which is actually a very interesting trial to take a look at. Dual KIT inhibitors. So Dr. Trent has this study. These are two drugs that are designed to work when you have those mistakes in the other areas of KIT. So trying to affect patients that have Gleevec resistant mutations either up front or later on. I'm running a trial that has axitinib plus immunotherapy, a drug called pembrolizumab or PD-1, Keytruda is the other name. GIST patients are eligible for this. And then, again, the crenolinab and Blue 285 are the ones that are out there for D842V patients. And we'll eventually have crenolinib and Blue 285s at some other centers. We're not going to have that one. So that's just the short list. So in the last few minutes here, I'm going to switch gears a little bit and talk about side effects because this always comes up. So life with imatinib, Gleevec. This is tough because these drugs are taken every day. So there isn't, with chemo or old traditional chemotherapy, you get a dose and then you have a break for recovery. But Gleevec is every single day you're on these medications. Sutent and Stivarga, there's different schedules, but oftentimes we're trying to treat you every day with those as well, maybe with a short break in between the cycle of treatment. Why do we get side effects? These drugs are dirty. We call them dirty. And what that means is that although they bind to KIT really well, they also bind to a bunch of other things, but not as well. And when they bind to other targets, or if they bind to KIT on your healthy cells, it causes problems and it causes side effects because it shuts down the growth of those cells as well as your tumor cells. The idea of doing this, though, is that KIT is so much more important for the gastrointestinal stromal tumor cells that we get a benefit even though it's still attacking some of your normal cells less well. So this is the reason why you guys wind up having side effects and why normal life is impaired from being on these medications. And I'll talk about those side effects here in a second. Couple things that I always tell my patients when they're starting Gleevec, you got to take it with food and water. If you take it on an empty stomach, it changes the way it's absorbed, and you may get really, really sick if you don't have the food, or you can actually underabsorb, so you're going through the Gleevec, but it's not getting the full impact. It's not getting absorbed completely. And the same thing can happen if you take Gleevec with medicines or even foods that impact the way that your liver breaks down the Gleevec. Just a few of these that you got to be aware of are an herbal antidepressant medicine called St. John's wort. Grapefruit juice is a no-no. Starfruit also is a no-no because it impairs the way your liver breaks down the drug. Coumadin also could impact it. For your cholesterol and blood pressure medicines, most of these are okay, but always have your doctor check and make sure that they know all the medicines you're taking to avoid any unexpected surprises. Tylenol and alcohol, we tell people to do it in moderation because it can stress your liver on top of the Gleevec. We always want to keep your liver happy, especially if you're on this for a long period of time. And iron supplements can also change the way the Gleevec's absorbed in the stomach, so we want to know about that. Most common side effects, so swelling and fluid retention is a big one. A lot of times patients will complain of swelling around the eyes. Here's a picture of somebody who has this. And that's really hard to manage. I mean, for most swelling, we try to use diuretics for other causes, but it doesn't really work well from the Gleevec-induced swelling in the legs or in your face. There's some tricks that I'll show you here in a minute for all of these different things. Nausea, vomiting, abdominal pain, constipation, diarrhea, basically anything in your GI tract can be a problem. Loss of appetite, fatigue, muscle, bone, joint aches and pains that are sort of modest but still annoying, trying to help people deal with that. Rashes, blood count changes, and then electrolyte changes as well. And so for all of these, the goal is to try to help people learn to live with these side effects, and I'll show you some tricks that we've come up with. The dangerous side effects that you really want to be aware of, so any shortness of breath that comes on all of a sudden, big problem, especially if your legs are more swollen than normal when that happens. Any chest pain, of course, we want to know. Skin or eyes turning more yellow, that's a sign of potentially your liver being stressed, and we want to know about that very quickly. Any severe headache or changes in your vision, and foamy urine, those are all some of the warning signs that we want to know about right away. For Sutent, Stivarga, and Votrient, there's a couple of other side effects that come up more often than Gleevec. So high blood pressure, almost everybody on these medicines will have high blood pressure, and that's actually a sign that it's hitting the target. These drugs, unlike Gleevec, which is mostly for KIT, these drugs also hit a protein called vascular growth factor, VEGF or VEGF. And VEGF for blood vessels is all over your normal blood vessels, and so that's why you get the high blood pressure. You also can be prone to bleeding and clots if you use these drugs, so we watch very, very carefully for those problems. Sutent will definitely turn you more yellow, and it may make your skin a little and hair a little bit lighter. Votrient is notorious for turning your hair ghost white. You'll actually see, and your skin as well, so that's something that we always tell people. Thyroid and liver are under a little bit more stress from these drugs than Gleevec. And then hand-foot syndrome. So this one's about the hardest one we have to deal with. So you can see in this picture this cracking, blistering callus that can form on the hands and feet. This is really bad. The less severe kinds is like a burning sensation in the hands and the feet. Can be worse when you're washing dishes in hot water or if you're handling something cold. And so we tell people for hand, foot that you really got to take care of your hands and feet. We give them a very rich moisturizer and tell them to exfoliate and really get that dried skin off. And then if we have to, we'll take a break from the medicine to help that resolve. So again, this is for you guys. I can make sure you have the slides available. These are some of the tricks we do for these side effects. Fluid retention and swelling, as opposed to the diuretics or the water pills. We'll tell you to watch your salt intake, avoid the really salty foods. Massage can sometimes help, especially in the legs, to try to push that fluid back. Support stockings, the TED stockings, are really helpful for some people. Nausea, vomiting, abdominal pain, and poor appetite, which is the one that people really complain about. So there's medicines to try to help with all of this, but we tell people to try to do small, frequent meals, become grazers. Your body doesn't know that it's hungry, or your stomach may be really sensitive to being distended with a big meal, and so we tell people to sort of snack smaller meals throughout the day. You also want to watch for any other medicines that might be causing your nausea or appetite to be a problem, and this can sometimes be pain medicine as well. Fatigue's really hard to treat. We tell people to prioritize their activities for the times that you feel the best. We encourage exercise, so push yourself a little bit during the time where you feel good, and then allow yourself to kind of make it up later when you're tired and take a little nap and just try to push yourself, because like anybody else, if you can exercise some, it will help not only physically but mentally. For aches and pains, there's a lot of tricks that people have come up with, including ivory soap tied to the foot of the bed. I've not personally tried that one, but tonic water. Diarrhea, we're fine with probiotics or yogurt that can oftentimes help with the diarrhea. Again, with the small frequent meals, keeping a food diary so we can try to track down exactly what's bothering you. The rashes, we talked about hand-foot syndrome a little bit. You will be sensitive to the sun on any of these medicines, so sunblock is especially important. And then for labs, again, you'll get routine blood work, and we're really watching liver, kidneys, thyroid, and then your blood counts. Those are the other things. And with all of this, keep in mind that I have some patients that come to me and they tell me that Gleevec's like a vitamin. They have absolutely no side effects. They're living their lives, and which people are going to have which problems is really, really tough to predict. But it's so individualized, you know, and that's why I tell people, if they're sort of on the fence about whether to use Gleevec after surgery, to give it a try, because if it's something that you can live with and you're really not having side effects, you may get a lot of benefit towards preventing this from coming back in the future. So the take-home recommendations from everything I've told you. Number one, know about GIST. So there is a ton of information out there. The Life Raft group has spent an enormous amount of time and energy creating this beautiful knowledge base that is open to you to educate yourself and educate your families. Days of learning like this are a great time to have access to all of us. Ask your questions today, make your list. We're here for you. Patient forums can be very helpful, especially with management of side effects and things, so that's another option. Take-home point number 2 is know your own GIST. If you have not had sequencing done, or if you're not quite sure, if people haven't looked to really understand what's driving your tumor, especially if it's changing, if something seems to be different, you really want to know as much as you possibly can about your own tumor, because we will customize treatment based on the biology of what's growing, and it's very individualized now, much more than it used to be. And then finally, know your options. So go out there, talk to people, talk to experts in some of the big GIST centers, and find out what trials are available. Find out what the newest science is looking at, so that you're ahead of the curve. And in case hopefully you don't need it, hopefully things are stable and good, but that way you're prepared and you feel empowered to take control of your own treatment, and not just rely on the every 3-month visit where the doctor tells you what to do. So take control, okay? So that's all I have. We have a few minutes for questions, and I will just open it up. Thank you very much. Yes, sir.
I have a 2-part question. If no mutational testing was done on a resected tumor,
Yep.
who would you not recommend, if there's any circumstance that you would not recommend take Gleevec if you didn't know the mutational analysis?
So again, you got to play the numbers a little bit. 80% of the time, you're going to be doing exactly the right thing, right? So 80% of the time, your GIST is most likely an exon 11 mutant tumor that's going to respond to Gleevec. So again, if it's a numbers base and you've been on Gleevec and your tumor it did what it needed to do, if that's happening, you can be pretty comfortable that whatever you have is probably sensitive. So that's where a lot of people will go. They don't do the mutation testing, but as long as the tumor is behaving like it's expected, you may not have to biopsy or do that testing right away. The time where it's really critical if you're in that situation is if the tumor starts to grow. At that point, when you're moving into those second and third line treatments, it's really important to know what's going on, in my opinion.
Let me clarify my question. Would you ever recommend a patient not taking Gleevec if you didn't know their mutational testing?
Would I? So I think if
you only knew their mitosis count, but you didn't know their mutation.
The mutation. Would I ever not recommend it? So for the really small tumors, the ones that are very low risk to begin with,
Like less than 2?
So less than 5 centimeters, less than 5 mitoses in the stomach, those tiny, tiny ones. If I'm not going to use Gleevec, I don't push so much for the mutation testing. Because at that juncture, I'm confident that because it's so small, the chance of it coming back is low enough that we don't necessarily need it. You can always go back and get your tumor later if you need it. And we can usually do the mutation testing on those preserved samples that are sitting in a pathology lab somewhere. Does that answer? Does that make sense?
Okay. But in today's science, isn't it routine to do mutational testing?
It should be, but it's not. It should be, but it's not. It's not in the guidelines yet. We're pushing for it to be in the standard guidelines that everyone does, but not all labs can do it. And so it needs to be sent to a special place to do that testing. Go ahead.
The data on all the slides and the statistics, is that gathered from your patients or Dr. Trent's patients together, or like a whole?
That's across. Most of the data, I don't think I have any of our specific data. This is across the board.
So they all pump the information into a source
Right.
that you guys got.
Right. Yep.
What are the chances of your metastases being a different mutation than the primary?
From the get-go? That's a good question. So we don't necessarily rebiopsy a metastasis if the tumor was high risk to begin with. If there's one area that's growing, the chance of it having a new mutation or something different is very high. And whether it's something we can act on is a little bit less clear. But for example, I had a patient who's now on Stivarga who's having growth on Stivarga. So that's 3 treatments. We did a biopsy on his tumor and came back with 3 different mutations than what he originally had. So if it's spread and it's changing behavior, it's very likely there's something else going on.
On a needle biopsy, is it possible to have enough material to do genetic testing?
It can.
Yeah.
Okay.
Mm-hmm.
Okay.
No problem.
I have a
Go
question
ahead.
that
Sure.
kind of just goes on top of that one. If the Gleevec stops working and all the alternatives have tried and they stop working, is it ever possible for a patient to go back to Gleevec and maybe have that start working again?
And have benefit. So I've actually seen it. I've seen that happen. And sometimes what happens is maybe the Gleevec hadn't completely stopped working, but it was sort of heading that direction. And then you switch to something else and something happens. We don't understand exactly why, but it reprograms the cells. So there are times where, say somebody progresses on 400, sometimes doctors will just go straight to Sutent or Stivarga out in the community instead of jumping up to 800. And there have been patients where I've gone back and put on the higher dose of Gleevec and had success that way. Again, it helps if you know, like if at that point you biopsy and there's still just exon 11 and it should be working, I'm more likely to try that as a next option.
I have another question also. The trials that you had mentioned, who would be eligible to be involved in them? And can you be a patient receiving treatment somewhere else and be involved in clinical trials?
So I won't go into all the details because there's specific rules for each one of them. The take-home point is that most trials require you, except for like the ones that are first line or second line where you haven't had you haven't had that treatment yet. Most trials require that whatever you're on right now not be working. So something has to be growing to go on most of these newer trials. So there's a time and a place to go on a study, and it's sort of about timing and knowing what's out there in case something happens. So if we had a new patient, Dr. Livingstone resected, or let's say that he's got advanced disease and can't go on surgery, and we're going to try this neoadjuvant approach where we do the Gleevec up front, those are patients I'd talk to about the Gleevec versus masitinib study and try to get them on that trial before they wind up going to surgery. You had a question? Yeah.
Two questions.
Okay.
The first one, you mentioned iron supplements. Is that, okay, so you said you should be taking the Gleevec with food. Are you talking about the iron supplements at the same time, or are you talking about in general?
So you can get away with taking the iron supplements at a different time during the day.
That's my question. So for example, I take a multivitamin in the morning and I take the Gleevec at night. Is that?
Multivitamin with iron?
Yeah.
Okay, that should be fine. The one thing I would just say is that iron supplements do tend to have other side effects like constipation, and so it's important to sort out whether you're truly lacking iron or whether your body's just slightly anemic because of the tumor itself or the Gleevec. So, or there's other types of anemia like B12, thyroid issues, and so if we have to use iron supplements, we can, but I just want to make sure that there's a reason to do that, because most people that have GIST may not be iron deficient unless they're bleeding somewhere.
We're going to have to go to the next speaker.
Sorry, we'll have time afterwards.
We'll have question
Thank
and
you.
answer.
Sorry. Okay.
Panel after.
Thanks, guys.